We are Team America, named by Casey. I am Amanda Meadows.
I'm Jennifer Tuttle.
I'm Sarah Capoletti.
Jamie Foster. I'm Casey Rose.
And our case study was Anthony. So the first thing that we did this summer was to choose a case study, and this is the one that we found most interesting to our group. So Anthony is a former Navy SEAL. He is recently retired, and he has been working on utility lines, and he was electrocuted. So he lost consciousness for about 48 hours. When he was at the hospital, he had an MRI which showed hypoxia, which is an oxygen deficiency that reaches the tissues. It also showed enlarged lateral ventricles and intracranial pressure, which damaged the cerebellum, which is very important for muscle control. He was given numerous medications to decrease the swelling, to prevent seizures, and to stabilize his blood pressure. While in the hospital, he was intubated orally to help with his breathing and with a PEG tube in the stomach for nutritional purposes. 2 weeks after he arrived at the hospital, he was moved to an acute rehab center. When he was moved there, he received a CPAP, which is a continuous positive airway pressure to keep the airways open, and he was prescribed a pureed diet. He currently presents with cognitive impairments, dysarthria, which is a difficult or unclear articulation of speech. However, he is otherwise linguistically normal. He has dysphagia or difficulty swallowing, which is why he is on the pureed diet, and ataxia, or a loss of full control of bodily movements.
So Anthony was assessed using the Rancho-Sloan-Vigo scale. This is a means of assessment that does not require the corroboration of a patient, and it's reliable for patients who have suffered a TBI of less than 1 year. On the Rancho-Sloan-Vigo scale, it's a scale from 1 to 10, 1 being there is no response to external stimuli, and 10 being that they're very active. So you want to be closer to level 10. In Anthony's case, he is a level 5, which he has a short attention span lasting only a few minutes in length. He is disoriented and has difficulty making sense of his environment. He has difficulty following directions. He's restless and easily overloaded. He becomes very tired and irritated when around too many people. He has very poor memory, including short-term, recent, and working memory. And he's overly focused on basic needs. For the family goals for Anthony, he has his parents. His mother and father are both full-time workers. He has a brother who goes to college 2 hours away and a fiance that visits him regularly. His family goals include communication, obviously. They want him to be active on social media, live independently, and be able to access public transportation and hopefully be able to drive.
All right, our EBP process. So this summer we started with our case study, and from that case study we derived a clinical question, and then we searched a lot of evidence, and then analyzed a massive amount of evidence that we acquired, and developed a clinical decision. The last two, implement decision and evaluate outcome, are really important as we go into our clinical practice, but for this project weren't applicable, really. So at the top of our next slide for the rest of the presentation, you will have this chart, and the blue square at the top is the part that we are at on that slide.
So you know Anthony, and you know a little bit more about him, and so from this point and from this information we made our PICO question. Our P for population are individuals with traumatic brain injury and subsequent dysarthria. Our intervention is behavioral treatment. Our comparative intervention is the use of compensatory strategies, and the outcome is increased speech intelligibility. So that's very fragmented, so I'll put it together in a sentence that will hopefully be easier to remember as we go through question is, do people with traumatic brain injury and associated dysarthria have a greater increase in speech intelligibility following behavioral treatment or use of compensatory strategies?
Alright, so the first thing we did was search a variety of databases with a couple of our keywords. We wanted to search with dysarthria, and we wanted to search with traumatic brain injury, as well as our interventions, which were compensatory strategies, as well as behavioral approaches. And some behavioral approaches for dysarthria include the Lee Silverman voice treatment, so that was also one of our keywords because we wanted to compare that to our compensatory strategies. After we identified several articles that we really wanted to use, we ranked them according to the hierarchy of evidence. And as you can see, we identified 3 systematic reviews as well as a randomized controlled trial, but the majority of our studies fell within case series studies as well as case studies. And we also consulted Dr. Brigeau for his expert opinion on the matter. And then after we arranged all of our evidence according to our hierarchies, we decided to analyze a couple of the key studies that we really felt would help us to answer our clinical question. So as you can see, we included articles from all case studies as well as a randomized control trial and systematic review. So we used things from all pieces of the hierarchy of evidence. Our first systematic review was a review of 63 case studies, and it was comparing a holistic kind of compensatory strategy therapy to traditional therapy. And the results of this review supported the use of holistic rehabilitation compared to more traditional approaches with individuals with traumatic brain injury just because of their behavioral and cognitive impairments. We also looked at a review by Yorkston and his colleagues, and this was a review of 51 case studies, and this was specific to just the treatment of dysarthria, so this didn't include individuals with traumatic brain injury, unfortunately, but we still felt it was important to look at this just so we had a better understanding about behavioral approaches in general. And the results of the review actually showed that there was limited evidence for effectiveness across a variety of behavioral approaches. So they actually didn't find much of an effect for treatment for loudness, speaking rate, or prosody for individuals who have dysarthria. But actually the strongest evidence for dysarthria is more just improving loudness in individuals with hypokinetic, which is usually associated with Parkinson's disease. We also used an article by Murdoch, and this kind of just gave us an idea of what kind of dysarthria would be typical for an individual with this particular traumatic brain injury. And the results of this study showed that this kind of individual would most likely have the most trouble with his articulation, which is true for our client. And then we also looked at a couple of case studies that were comparing the behavioral approaches to more traditional therapy, and we found that the LSVT, which is the Lee Silverman, which is a behavioral approach, resulted in greater intelligibility for individuals with traumatic brain injury and dysarthria. And then we still wanted to look at more compensatory approaches, so we looked at an article by Husted, which compared different strategies for speech supplementation, specifically using alphabet boards and alphabet cueing and topic cueing. And the results of the review showed that alphabet cueing combined with topic cueing resulted in the greatest intelligibility for individuals with traumatic brain injury and associated dysarthria. And our final article that we decided was a key one was an article examining LSVT again, which is a behavioral approach, and it did actually result in increase in intelligibility over time. So all of these articles in whole kind of helped us to make our clinical decision moving forward with Anthony. So because Anthony is still recovering from a traumatic brain injury, it's important to consider where he's at right now as well as where he's going to be moving. So for Anthony's given condition right now, we thought it would be most appropriate to focus on compensatory strategies so that he can convey his basic needs most efficiently with the least trouble possible. So we thought about some low-tech AAC strategies and very simple communication boards that would help him to just communicate with his nurses and the rehab team and just kind of support any kind of interactions where he may not be understood when he's trying to speak about his primary medical needs. And this is something that could also be added to as he recovers. He can maybe have some more complicated boards as he continues to improve, and they can lead more into commenting and supporting his social interactions within the rehab setting. We also felt it was important to consider some no-tech AAC, which is something that Anthony could use without a communication board or anything added to him. We could help him to use his gestures to communicate a little bit more efficiently and kind of just cue his communication partners about what he's talking about. And also make use of any type of writing that Anthony still has. So for individuals with traumatic brain injury, usually writing is still intact, so hopefully we could make use of that to help him communicate as well. And then we also thought it would be important to consider some family counseling, because currently the goals for Anthony from his family are pretty high. So we felt that might be a good initial step to just talk with the family about what their goals were for him and kind of make sure that they had a good understanding of his whole prognosis as a whole, and really support like making sure that they were setting appropriate goals for Anthony.
So as Jamie said on the previous slide, based on Anthony's status as a level 5 on the Rancho scale, compensatory strategies and use of compensatory strategies are the best option for him at that level. So that eliminated 50% of our PICO question, because behavioral approaches were not really appropriate for him at that stage. So what we thought about was next steps in Anthony's care and where we would take it as he healed and improved. And we graduated him on the Rancho scale to a level 6 and approaching a level 7. And he, at that point, would have the ability to answer questions appropriately in context. He would be able to relearn some skills and behaviors that he had before the accident, and he would be able to kind of carry that over into learning some new things. So at this point, we could continue to think about our PICO question and maybe integrate some behavioral approaches for Anthony. We would target some things that were mentioned in the Lee Silverman treatment, where we have a slower rate of speech, increased volume, and those two things go together because the louder you speak, the slower you speak. And some rhythm to target the mono pitch and mono loudness that is associated with ataxia dysarthria. Then also postural support so that he can independently position himself to be in an optimal position to have breath support for his speech. These are things that we considered potentially within the realm of possibility that he could conceivably target at this point. We didn't want to be overly zealous and think that he could do a lot because he had a very severe injury and he is in a very lengthy recovery. So, and just as Jamie mentioned some compensatory strategies for him at level 5, we would graduate those as well as he continued to heal into some new compensatory strategies. And the Houston article in particular, trying to go around too soon. The Houston article in particular looked at different speech supplementation and judged the difference in speech intelligibility based on the different cues. The first cue that she examined was alphabet cues. So with alphabet cueing, you indicate the first letter of every word that you're saying to help your listener understand what you're saying. So you could say walk, dog, or happy birthday, grandma, or something like that. Things you would say every day, clearly. So the alphabet, that was alphabet cues. The next were topic cues, which you were indicating the topic that you were discussing with your conversation partner. Not the alphabet cues, only the topic at hand, the general idea of what you were talking about. And then the third was combined cues, where you combine the alphabet and the topic. And from that research, the results showed that alphabet cues alone were actually the most effective, with between 16 and 44% increased intelligibility. The second was combined cues with between 35 and 40% increased intelligibility. And the third was topic alone, which only had 3 to 16% increased intelligibility. The situation was highly regulated. There were pristine listening conditions, and it was probably not transferable to have those expectations in a more regular, natural environment. But those results were promising, and we think that with Anthony, the best approach would be a combination of compensatory strategies and behavioral approaches, mostly because the research didn't show that one was particularly more effective than the other, and the use of both could help him improve his speech intelligibility.
All right, future research. We really wanted more research on treatment related to speech intelligibility because what we were finding was increased loudness. So it was telling us to increase the loudness, no, increase the speech intelligibility, which is not always enough to make them intelligible by people. Next, we wanted examination of compensatory strategies. So instead of just our alphabet and our topic, cueing more and seeing how they related. And then generalization of abilities following treatment. So like Sarah had said, our research articles had pristine conditions, quiet environment, not realistic, and we wanted to see what that would look like following a treatment in a realistic environment. And then our last one was research related to cognitive decline following TBI, because it is very different than cognitive decline of anything else like dementia or post-stroke.
These are some of our references, and we would like to thank Dr. Rougeau for his guidance and support with this project. During the process, we met with him to kind of give him our ideas and for him to help us out a little bit more with the project. And these are them. Thank you.
What do you think was the hardest part about finding research?
Well, I think the hardest one was because of our population, because it was traumatic brain injury with dysarthria, and a lot of the research was mostly on just individuals with dysarthria and not a traumatic brain injury. So it's hard to get both of those together for an actual intervention study.
I would add to that too. Dysarthria, especially with traumatic brain injury, is comorbid with so many other things that I think different things get researched before dysarthria because it's not always the most pressing issue for these people. So I think that was a limitation as well.
Thank you.